have on stage Dr. Reni Philip, and she's presenting on is it all relative, biometry and relative lens position in glaucoma and its effect on disease severity.
Good afternoon. Thank you for this opportunity to present the results of our study, Is it all relative, biometry and relative lens position in glaucoma and its effect on disease severity. Several biometric factors are known to be associated with glaucoma. In open angle glaucoma, the axial length is longer, whereas in angle closure glaucomas, the axial lengths are generally shorter. Additionally, the anterior chamber depth is lesser, but the lens thickness is more, and the lens is a little more anteriorly positioned in angle closure glaucoma. So in Asia, angle closure disease is much more common than in the West. And incidentally, we also have rising numbers of myopia. And it has been found that in angle closure disease, myopia can range between 0.09 to up to 22%. So these eyes may be longer, but they have a relatively narrow anterior chamber despite the longer axial length. Few studies in literature report the relationship between biometry and severity of glaucoma. Considering all this lacunae, we conducted this study to assess the ocular biometry in normal, open angle glaucoma, and angle closure disease eyes, which includes angle closure suspects, angle closure, and angle closure glaucoma. And additionally, in primary glaucomas, the angle closure and open angle, we also wanted to look at glaucoma severity using VFI and mean deviation based on the relative lens position. We prospectively recruited subjects in the glaucoma department of a tertiary eye care center who had vision of at least 618 and were phakic. And we excluded those having other ocular diagnosis other than the normal patients, the open angle glaucomas, and the angle closure disease. Additionally, glaucoma suspects and anyone with diagnostic dilemma were also excluded. We then analyzed results from 942 eyes of 474 patients and took details from history comprehensive evaluation, visual fields, and refraction for this study. The biometric parameters that we assessed included the anterior chamber depth, the axial length, the lens thickness, the lens position, which was calculated as anterior chamber depth plus half of the lens thickness, and the lens position divided by the axial length was the relative lens position, which we use as a proxy for crowding of the anterior segment. We used the appropriate test, and a p-value of less than 0.05 was considered significant. On looking at the results of patient characteristic and refraction, all factors were significantly different among normal angle closure disease and open angle glaucoma eyes. And the median age was highest in the angle closure glaucoma group, and the open angle glaucoma had the most myopic eyes. And in biometry, the angle closure glaucoma group also had the highest lens thickness and the least relative lens position, that is, eyes that were most crowded. We looked at the refractive errors depending according to diagnosis, and though we had myopes and hypermetropes over all the groups, it was generally seen that myopes were more common in open angle glaucoma and the hyperopes were more common in the angle closure disease eyes. Interestingly though, in open angle glaucoma, about 31.4% were hyperopes, and in angle closure glaucoma, about 20.6% were myopes. So we assessed patient character and biometry in angle closure disease and found that angle closure glaucomas was significantly older than the primary angle closure suspect or angle closures. And these also had slightly lesser hyperopia compared to the other groups, and the axial length was also slightly longer in the angle closure glaucoma group, as was the anterior chamber depth. However, the relative lens position or the lens thickness was similar among these three groups. We then assessed the difference in disease severity using VFI and mean deviation on visual fields and characterized these features depending on the relative lens position outliers, that is, those less than the 25th percentile or the slightly more crowded angles versus those greater than 75th percentile or the slightly wider angles in the angle closure glaucoma group and open angle glaucoma group were separately assessed. These results shown in the table are summarized here in this slide, which shows that the greater than 75th percentile angle closure glaucoma patients had higher age, higher spherical equivalent and lesser axial length and higher anterior chamber depth and lens thickness that was significantly different from the less than 25th percentile group. But in both the open angle as well as angle closure glaucoma eyes, the visual field index or the mean deviation did not differ significantly significantly among the outliers. We also did a multivariate analysis and found that once you control for age and gender, none of the biometric or the refractive parameters were found to be significant. So we prospectively assessed the biometric parameters of patients in normal, open angle glaucoma and angle closure disease categories. There was a significant gradation of axial length and anterior chamber depth, with angle closure glaucoma eyes having slightly larger values compared to angle closure or angle closure suspects. This suggests additional anatomic and dynamic factors that are responsible for angle closure disease severity. And though I say that angle closure glaucoma eyes had the longest median axial length, it was still much shorter than the value seen in normal eyes. Compared to the study by Lee et al., who noticed that severe glaucoma had longer eyes and milder moderate, in our study, we were not able to find any differences in mean deviation of VFI depending on the relative lens position or axial length. And we noticed that angle closure glaucoma eyes was slightly longer than the angle closure or suspect eyes, which was similar to the results from the Chennai glaucoma study. And similar to Young et al., who looked for myopia less than or equal to 0.5 diopters and found that 27% was seen in angle closure glaucoma. We had slightly lesser values because of the slightly different criteria, and we had a value of 20.6% and 31.4% for open angle glaucomas. So one of the limitations of the study is that we did not have any follow-up data because it was a one-time cross-sectional study, but we did recruit our patients prospectively and look at the disease severity using biometry and glaucoma. To conclude, the relative lens position is a severity of glaucoma is not affected by the relative lens position, and a longer axial length and anterior chamber depth in angle closure glaucoma suggests that additional non-biometric factors may be responsible for severity in angle closure disease. These are my references. Thank you for this opportunity.
A nice study. But you had some slightly varying results from already published reports, no? The axial length as compared to results which you compared with the existing literature, slightly varying results were there, no? Slightly.
The values were slightly different.
So
Yes, sir.
any logic you propose for that? Like
for the values, sir?
Slightly different in India, our population.
We took a different sample and the numbers were also different. So as a result of that, we had slightly different median values. We used IOL Master 700. In this, the Chennai glaucoma study, they used the ultrasound A scan. So the machines were also a little different, but our data set was also different. Thank you, sir.